So next on the anticoagulants or on the anticlotting drugs. So of the heparins and direct factor 10 inhibitors, and we've talked about direct thrombin inhibitors. So the next on the list is warfarin, which is usually given orally. So it's a coumarin anticoagulant, and it has lipid soluble. It's small sized. It's readily absorbed after an oral dose. However, it's highly bound to plasma proteins, and it's eliminated by CYP450 enzymes, and that can potentially cause many drug interactions because of its nature of being eliminated by the CYP450. So as you know, warfarin was originally intended to be used as a rat poison to kill rats, bleeding them to death. So it interferes, this drug, warfarin interferes with the normal post-translational modifications of clotting factors in the liver, okay, which is a vitamin K dependent process. And the vitamin K dependent factors include thrombin, so which is factor 2, and factors 7, 9, 10. So it's 2, 7, 9, 10. So these are the vitamin K dependent ones, and they are the ones that are interfered by warfarin. And so as it is a vitamin K dependent process, so the action of warfarin can be reversed by giving vitamin K. However, this is a slow process, taking about 6 to 24 hours. And to get a more rapid reversal of the bleeding caused by warfarin, so we have to transfuse with fresh or frozen plasma that contains normal clotting factors, okay, especially 2, 7, 9, 10. So we have warfarin blocking factor 2 prothrombin, and then factor 7 in the PT pathway, extrinsic pathway, and then in the long pathway, okay, inhibits factor 9, and in the common pathway, warfarin inhibits factor 10. So 2, 7, 9, 10. So these are the vitamin K dependent factors. So for this one, however, we have to monitor only the PT, prothrombin time. Okay. So indications for warfarin, it's for chronic anticoagulation of all clinical conditions. Okay, as were mentioned for heparin, except for pregnant women. So we cannot give warfarin to pregnant women. Adverse effects include bleeding, obviously. So this is a bit different. We have dermal vascular necrosis. So necrosis of the vessel of the skin. And then we have bone defects and hemorrhage in developing fetus. So that's why it's a big no-no. to give pregnant mothers warfarin. And as I've mentioned, because of the CYP450 metabolism, so it can cause drug interactions with anti-epileptics and other drugs such as carbamazepine, phenytoin, etc. So this is just a question. So a 35-year-old lady with history of 2 previous lower limb DVT presents again with another DVT. So 2 previous DVTs of the lower limb, and then again another DVT. And she has a thrombophilia screen performed, which shows the presence of lupus anticoagulant. So what is the best course of action? Is it to give aspirin and warfarin, long-term low molecular weight heparin, warfarin for 6 months, or warfarin lifelong? So what is the best course of action for this patient? So the answer is E. So we have to give lifelong warfarin to this patient. So this is the evidence suggests that we give this patient lifelong warfarin because of the 2 DVTs and another DVT, and then because of the presence of the lupus anticoagulant. And we have to give them warfarin lifelong and maintain an INR international normalized ratio of above 2.5. So this is a very favorite or common question in exams. Okay, what are the differences between heparin and warfarin? Okay, because I have not mentioned it in detail in this talk, so you have to find out about the differences and it's mentioned in many tables in many books. Okay, at least they will mention, I think, maybe 5 or 6 differences between heparin and warfarin. Okay, so check that out. Next, we go to the anti-clotting drugs, the second big category, which is the thrombolytics. So we have TPA derivatives and then streptokinase. So the endogenous tissue plasminogen activator, TPA, such as alteplase, tenecteplase, and riteplase. So these are usually given intravenously to the patients. And then we have streptokinase, okay, which is very popular, very commonly used in probably all countries in the world. Okay, and this is a protein that comes from the bacteria Streptococcus, okay, or the Streptococci. So this is how it acts. So we have the conversion of plasminogen to plasmin, okay, and then from plasmin to it enhances, okay, it promotes the conversion of fibrinogen to degradation products, so it causes the lysis of fibrinogen here, and also it causes the lysis of fibrin, okay, to fibrin split products. So for fibrinolytics, okay, or thrombolytics, Okay, thrombolytics. Then we have the fibrinolytics and streptokinase. Okay, so fibrinolytics, we have the both TPA derivatives and streptokinase. So these are the thrombolytics or fibrinolytics. So the act here enhance the action of plasmin, so that plasmin can degrade fibrinogen, can degrade fibrin. Okay, so that's how TPA derivatives such as alteplase, etc. act, and similarly streptokinase. So we have TPAs, and then we have streptokinase. So just a short recap. So we have the artery and then the plaques forming, and then the plaque grows in atherosclerosis, and finally we get the lining of the artery, which sometimes get damaged, and then the plaque ruptures, and because of the rupture, so we have the coagulation mechanism coming in, okay, jumping into to stop this bleeding. So the blood clot forms and it will limit the blood flow. And this is where we want alteplase, the RTPase and the streptokinase to act, okay, and dissolve this thing. So we want it to dissolve fibrinogen, dissolve fibrin. So streptokinase and the RTPase, they are the alternative to percutaneous coronary angioplasty, okay, in the treatment of coronary artery thrombosis. So this is angioplasty. So with stenting, that's what you do, put a mesh there. But if you don't do this, then the alternative, okay, you usually try to give streptokinase within the first 6 hours of the attack, of the onset. And this can recanalize the occluded coronary vessel, hopefully. Okay, so if it's occluded, so we give streptokinase hopefully within 6 hours, so it will be able to recanalize this. Okay, and for RTPA, for TPA, like alteplase, so if give within the first 3 hours, then we hope for better outcomes in ischemic stroke. So what are the contraindications to fibrinolytic therapy? What are the contraindications to giving TPAs and also streptokinase? So there are absolute ones and relative ones. So absolute include previous intracranial bleeding. So if you know that the patient has a structural cerebral vascular issue, like a Barrett's aneurysm, perhaps, and then if the patient has known malignant neoplasm in the brain or have previous ischemic stroke within the past 3 months before coming, or if the patient is suspected to have aortic dissection, or the patient is having active bleeding, which is not related to menses, or there was a significant closed head trauma or facial trauma within 3 months before coming, then that's absolute. Relative contraindications include having uncontrolled hypertension, traumatic or prolonged CPR, cardiopulmonary resuscitation, or major surgery within the past 3 weeks, recent internal bleeding, non-compressible vascular punctures, okay, and prior exposure, okay, or prior allergic reaction to streptokinase, pregnancy. So that's a relative contraindication to streptokinase and TPAs, active peptic ulcer, and the current use of warfarin, and INR more than 1.7. So these are the relative contraindications to warfarin. See you guys in the next slide.